Welcome everybody. I'm Jerry Menikoff. I'm with the Office for Human Research Protections, a part of Health and Human Services. And today we're going to do a mock IRB. So lucky you who are actually here, you are actually going to serve as an institutional review board. And we're going to sort of do what an IRB would actually do. We have a protocol to review. Hopefully you've all kind of looked at some of the background materials. So let me just recap a little bit. Hopefully some of you have heard the talk from yesterday and have read about what IRBs do. Institutional review boards are entities that basically, and this is sort of unusual, they're private entities, they're often not part of the government, that determine when a study with human subjects actually can take place based on certain rules, certain protections that have to be in place, and that these are the committees that determine that the protections have been met. And it's an unusual thing because often in terms of the law and the government and everything, there are often governmental bodies that review things that determine the appropriate protections are in place. But here it's sort of been delegated to this unusual type of entity. And there are lots of them out there. There are thousands and thousands of IRBs, both within the US and across the world, because many other countries have very similar rules in terms of human protections. They don't necessarily call the entity an IRB. It may be called an ethics review committee or research review committee or something like that. But effectively, they do the same thing. So what will happen is a researcher comes up with a protocol, and they then submit the protocol to the entity that administers the IRB, and depending on the protocol, it will actually be reviewed by the convened IRB. And certainly for studies that are more than minimal risk, in general what happens is the committee meets from time to time. It depends on the institution. There are very, very different types of structures that institutions have in terms of whether or not they have internal IRBs, or as I mentioned yesterday, there can be commercial private IRBs in which the institution just sends out their studies to be reviewed by that entity. If it's an internal IRB, again, there could be different IRBs for different types of topics. And so NIH has quite a few different IRBs. Different of the institutes and centers have their own IRBs. Some IRBs cross institutes and centers. And the IRB may meet like every 2 weeks, for example. It may be an IRB that only reviews cancer studies. It may be an IRB that reviews social and behavioral studies. Again, it depends on the structure of the institution, the resources, what kind of research they do, all that sort of stuff. So what will happen is the IRB gets together, and the review of the study actually, they don't have to all be in a room, but what we're doing here is ideal and very similar to what a lot of IRBs do. Often you'll be sitting around a table. You actually can meet by telephone or teleconference or video conference or that sort of thing. You cannot meet by sort of like sending emails to each other. You have to actually be able to sort of communicate at the same time and actually discuss stuff. And currently, sending emails to each other or text messaging wouldn't be considered to meet the standards. Okay, so that's the basic of what IRBs are. You have to have a variety of different backgrounds, as I'm sure we have here, and you're actually a good size. What do we have, 10-ish or something. IRBs need at least 5 members, so we're kind of in the ballpark in terms of all of that. So we have NIH's protocol review standards, which are pretty much just NIH's internal interpretation of what an IRB might actually think about, and it's sort of handy. They've actually put questions that you might want to ask yourselves as the IRB reviews the study. There are different ways IRBs actually review studies. A very common way, just in terms of administering the workload, is that there's a primary reviewer system, and often that means that each, in particular, a new protocol. Let's imagine today we're reviewing new protocols that have never been in place before. Often there are new protocols, and then there's what's called continuing review. In general, every year or less than a year, an IRB has to re-review a protocol to make sure it still meets the standards. And depending on the IRB, you may have separate meetings where you just review new protocols, or you may devote part of your meeting to new protocols and part of your meeting to continuing review. So those are some of the basics about how IRBs operate. And so we're going to be an IRB in a moment or two, and we'll be reviewing a new protocol. Any questions about, the general issues relating to how IRBs operate or that sort of thing? And so what I'm going to do, since you're going to do a fair amount of the talking, we have this microphone, and you'll just be passing it back and forth to each other whenever one of you wants to talk. So I was telling you about the primary reviewer system. So, right, to manage the workload, a new protocol comes along, and a bunch of administrative people make sure it has the right information. It's a lot of background documents that often the researcher has to fill out when they file the form. And assuming they've all done it, and the protocol is then assigned for a particular convened IRB meeting. Let's assume today we're doing the meeting, and it's the first protocol we're going to review is a new protocol. Ahead of time, probably 2 people often will be assigned as primary reviewers in that protocol, and they will spend more effort looking at that protocol and being prepared to sort of present it to all their colleagues so that they'll understand it. Now, by and large, all the members of the IRB are supposed to look at least the core documents relating to all the studies being reviewed that day, but again, in terms of workload, the 2 people assigned to be primary reviewers spend more time, in particular, on the ones that they're assigned. They really dig into it, and they should be prepared to answer questions from their colleagues. In some institutions, they will actually invite the principal investigator to part or all of the IRB meeting to ask him or her questions, or to have them make a presentation, whatever it is. That's variable. I mean, some IRBs do it, some IRBs will not do that, and they might do it if they review the protocol and then discover they have a lot of questions, and it's certainly not approvable in their eyes the way it's originally written. So the second time around, they say, we're going to review it again, but we want the investigator to come to the second session to explain something and answer questions in person. So those are some of the basics. So we're now going to start. We're wonderful IRB here, and we have this protocol relating to administering cocaine. You probably noted it's sort of a somewhat unusual protocol. It certainly raises a bunch of issues. So what we could do is, and we don't have to adhere to exactly this is very free form. And again, IRBs could bounce back and forth in terms of what particular questions they'll address at one point or another. But certainly so I'm initially looking at the IRB protocol review standards. Like this is on the second page of the document. It sort of has the little, checklisty sort of thing. And what this is going through is it's going through the actual review criteria. And these are exactly the criteria we actually discussed yesterday. And it's posing a number of questions. And if you want to be able to talk a little as our IRB meets, you may want to get a little closer. They're trying to get people sort of on this side. Because I only have one microphone to pass around. So we're just getting ready to get started in terms of being our IRB. So this is giving some suggestions about questions that an IRB might want to ask itself. So the documents we're going to be looking at are these questions, the review standards, and we actually have our protocol for our study, and we also have the consent form. And again, these are all the pretty standard documents that an actual IRB would have at its meeting. In particular, the protocol and the consent form would be very, very core documents. And again, in terms of the submission documents, that may often just ask particular questions, so it's easier for the IRB reviewers to know exactly where to find something. So it may ask them to repeat certain parts of the protocol as an answer to a question. So why don't we start with number 1, regulatory review requirement. The proposed research design is scientifically sound and will not unnecessarily expose subjects to risk. And you're going to see in terms of suggested questions for IRB discussion, is the hypothesis clear? Is it clearly stated? Is the study design appropriate to prove the hypothesis? Will the research contribute to generalizable knowledge? And is it worth exposing subjects to risk? So starting out even with A, the very first part of this is the hypothesis clear? Is it clearly stated? What often happens is the primary reviewers begin by explaining to everybody else, what is this study about? And so we already have an answer here, right? Is the hypothesis clear? You're indicating it is. Maybe you want to say a little bit about kind of what is this study trying to prove?
Well, they want to see if the rate of infusion.
I think closer to the mic, I assume.
If the rate of infusion of cocaine.
Do we have the mic on for the? Yes. Okay. Hopefully.
If the rate of infusion of cocaine affects the physiological changes in the human body, so depending how fast it's given, whether there'll be any effects, and also dose dependent, how fast and how high of a dose. So.
Okay. Okay.
Hypothesis.
Okay. Very good. Others want to kind of expand on that? Because again, we want to understand this protocol enough so that we could understand everything they're trying to kind of figure out and why they're trying to figure this stuff out. So you're talking, yeah, okay, good. Okay. Close to them, I think closer to the mic.
They want to see because they're mentioning examples of, for instance, nicotine or diazepam or other drugs that have been studied before, but we don't have actual, we just use arbitrary knowledge, something that we really don't know about cocaine. And the way it can be used, if somebody is cocaine dependent, can this actually help them stop being dependent? Because so far there is no such thing as dealing with cocaine abuse. So it technically will help us get good knowledge about it.
Okay, and maybe you want to, I don't know if we want to flesh that out a little further. So everybody comfortable enough about what the study in terms of its purpose and that sort of thing. So we're looking at dosing issues, and I guess you've already explained some of this. So our basic two parameters that are being varied in this study are...
Are you talking about the physiological changes, the heart rate?
Well, in terms of what they're altering, in terms of what they're doing to the people, they're altering the dose.
The dose and the infusion rate.
And the infusion rate, okay. And now in terms of what they're looking at, right, so...
the EKG changes, the blood pressure, the heart rate, and what they actually mentioned, interestingly enough, is that so far the studies that were done before were not conclusive, but they were mentioning, I think, from the 1989, giving the higher doses. So that's additional, actually, a good thing that the dosing that they're giving, 10 and 25 or whatever the milligrams they're giving, is high. It's not as high as it's been given before, if I remember.
Okay, and yeah, right. So we'll get into issues relating to what's been given before and its relevance to all this. So they're looking at the dosing. They're looking at the infusion rates. Their goal is to learn something you already indicated in terms of perhaps treating people who are already addicted to cocaine, right?
Just a little bit more.
Yeah.
So you were mentioning the physiological changes, but they're also interested in psychological changes and if there's actually a interaction between dose and infusion rate and how high essentially they get with stable physiologic doses or differences, because there's different psychological reactions depending on the way that people in the real world will actually ingest cocaine. So that interaction is important.
So let's say more about...
I'm just going to be a devil's advocate here for a minute, and
Sure.
To propose any clinical question in clinical trial, it's important to see if that's an answer or a question worthwhile taking the risk to answer, right?
Absolutely.
Till this very day, there is no set limit to know that in a certain human being we can determine the speed of cocaine infusion to cause cardiac arrhythmia and death. And I think there was 2 trials that tried to look at this in the past, and depends on the physiological stance of that human and propensity to arrhythmia, it's difficult to determine which dose at which rate. In this study, the risk subjected to those subjects having cocaine at certain infusion with increasing rate is subjecting them to risk of death. So is the question being proposed worth taking that risk? What are we going to know from this study, which is so important to propose those subjects to that risk?
So you're saying you think there is a possible risk of death?
There is.
At the,
The protocol, they'll mention somewhere that the people who were to be entered in a study, they had to have experience of infusing about per certain amount for 10 seconds. I
Okay.
think there is a specification what would make them eligible for the study.
Absolutely. So you raise a great point, and we're going to get into the risks to some extent, right? It's already starting about, I guess, C here. Will the research contribute to generalizable knowledge, and is it worth exposing subjects to risk? I think the way they pose the question here, they're not getting into the level of risk yet, and later on we'll get into how high a risk is being people are being exposed to. But let's follow up with your broader point in terms of, so what exactly and I think between you two, we were starting to flesh it out. So in terms of the direction you were going in, maybe say a little more in terms of how exactly are they going to use the knowledge they might generate from this study to, for example, help somebody treat people who are currently addicted to cocaine, right? And you are getting into the direction, and maybe I'll get more in terms of answering your question, right? Why do they think the knowledge from learning a little more about how doses and infusion rates interact can then be useful in treating and creating possible treatments for cocaine addicts?
Right. So as I understand it, there's really no standard administration of cocaine along with treatments right now. And so if they can find a dose and infusion rate that leads to high levels of psychological side effects and minimal physiological or stable physiological side effects, they can give that in addition to whatever treatment they're testing to see if they can then prevent the addictive effects or get people down from the high faster or whatever the future studies would be doing.
Yeah, no, so very good. So in other words, they're claiming as part of their hypothesis that there will be differences in terms of as you alter both infusion rates and the dosing, you're going to see differences in terms of the two broad categories of things they're measuring, both the physiological effects and the psychological effects. So by looking at that, you could somehow, come out at this sort of ideal point in which you could minimize the possibility of the physiological effects and yet be getting a substantial amount of psychological effects. The premise being, if you in fact could do that, that's sort of a sweet spot in terms of then being able to go on in future studies and perhaps ideally come up with a possible dosage that will allow these people to feel the appropriate psychological effects, yet not be risking the death that you're referring to. Now we have a question back here, or maybe a comment.
I just wanted to address the suggested questions under B. I think we've talked about A and C, but is the study design appropriate to prove the hypothesis? And I don't really know that much about statistics myself, but I would really want someone with a statistical background to say whether this study, with the number of patients enrolled, is going to be able to answer their question sufficient to the level of risk that they're putting the patients.
Okay, no, an excellent question. And even if there wasn't much risk, by and large, if there's any risk and you're doing a study that would be called, I guess, underpowered, you're not going to actually have any chance of producing a result that's going to give meaningful information, unless it was a pilot study and you just want to see, initially you want to be able to do the steps in conducting the study. But if you're not going to get enough data to even have a possibility of producing meaningful results, that would clearly be a bad thing. And that's often the way people, certainly in the ethics field, often describe this, is basically that any poorly designed study is almost by definition unethical, because zero level of risk is appropriate in that circumstance, because you have no chance of having anything good come of it, and therefore you shouldn't be exposing people to risk. It certainly does sound like, for those, and I'll certainly put myself in the category of pretty naive about statistics, they're not having a lot of subjects. What, they're going to have like 12 or something?
And they also expect for a lot of those subjects to drop out, and so they're going to have some problems with
So,
But it's within subjects, which greatly reduces
You
the
wanna-
number of ends that you need. The strength of their design is that it's within subjects so that you reduce the number of ends that you need. I don't know if the 20 that they recruit and the dropout rate will lead to enough. I'm not that good at it, but at least it has a chance, I think, with this design.
Anybody who wants to say more or knows more about statistics. The protocol does actually say their numbers are actually a little higher than is normally done in this type of study, which would suggest, if they've done their work ahead of time, that in fact, as you indicated, right, that because you're comparing each person, and each person is going to have 9 separate, well, plus 10, a placebo, will have 9 separate interventions, that the statistics work. But bottom line, you're raising exactly the sort of issue that a good IRB will raise. In fact, it is often the trend these days that IRBs have like in-house or member statisticians, or else, and we didn't really get to this, often a study will undergo separate scientific review by a scientific review body before it hits the IRB. Notice that it is the responsibility of the IRB ultimately, as we're discussing here, to determine that this study meets the standards in terms of science. In other words, if the science is bad and it's not going to prove what it says it's going to prove, then the IRB should not approve it. It is sort of, again, by definition, almost unethical. And this creates a tension. I don't know if any of you, well, I'm sure some of you are investigators or you deal with investigators, and often there's a complaint from investigators. Their study may go through a scientific review board, and then it hits an IRB, and the IRB is asking the investigator questions about, well, from a scientific viewpoint, this doesn't make sense, or whatever it is, and it's like, wow, why is this IRB? They're an ethics review board. Why are they questioning me about the science? They shouldn't be worrying about the science. Well, it is perfectly legitimate for the IRB to do that. Ultimately, the IRB has to make its own determination. The questions we ask, that's part of the regulation, right? You have to determine it's appropriately scientifically designed and meets the general standards for science in terms of what it's trying to prove. This is an independent duty of the IRB. Therefore, even if it went through scientific review ahead of time, either the IRB has to look at that scientific review and determine it was appropriate and it agrees with it, but it's perfectly appropriate for the IRB to question it and to look at it and think about it. It's not like, oh, it went through scientific review already, the IRB should just not even address that issue. That is just not correct, and hopefully now you understand how the scientific review ties into the ethics. So basically, it is an independent IRB responsibility one way or another. It could end up knowing a particular scientific review board that reviewed the study and knows that they're great, and it doesn't spend a lot of time second guessing it. On the other hand, in a particular study, it may look at this and say, well, we don't know who reviewed it, and even doesn't make sense to us. Perfectly legitimate for them to do it, but you will get investigators who will be totally bummed out by this and like, wow, it's the ethics review group. Why are they wasting my time on this? I was within NIH here for a while, and it is common among NIH IRBs to actually have a lot of the discussion spent on the science of the study. And there are huge debates, I think, within NIH about whether the IRBs are spending too much time on the science review as opposed to, again, some of the other questions that are a little more what most people would consider ethics related. Okay, so we're doing a great job here. So I take it everybody's okay with the hypothesis being clearly stated and clear. Anything more about the study design? So we've looked at whether it is appropriate in terms of the numbers. Any other aspects of the study design people want to get into? You can pass the mic back. And you may want to describe more of the study design if you want.
Well, they talked a bit about wanting to do this experiment in order to maybe create some sort of standardization so that future studies can be done that look at potential medications for people with cocaine addiction. But I'm wondering, is someone in the process of developing those medications? Are they on the horizon somewhere? Because if they're not, I'm not really sure it's worth putting these subjects at risk.
Okay, okay. It's a very legitimate question to be asking. And I don't know if anybody wants to respond to that, but it's a good point. Now, I guess even if they weren't developing those medications, I guess you could still use this information relating to cocaine itself and future tests relating to cocaine, and I guess
the research first in order to develop the drugs, not the other way around. I mean, they need something to start.
Okay, so you're raising a point. Do you need to do the research first before you figure out then what drugs might be able to do this? but probably this research study isn't going to tell you how you design a drug that might be a surrogate for taking cocaine or something, I take it. But, okay, and you,
So I'm just going to talk a little bit about
and
the
talk into
scientific background for this. So in any addiction component to a study, there's always the part that it treats the addiction component, not regardless of the substance, and that has to do with a lot of behavioral modification and certain antagonists that deals with opiates or noradrenaline reuptake inhibitors like cocaine. So that's one deal of it, and these medications are up there and available. The problem, I think, they want to use this as an adjunct treatment, because in each and every addiction treatment trial, you do have to have some sort of a maintenance dose of the addiction drug to go with the treatment to be able to taper it off. So I think they were trying to figure out if they can give this medication to give the high at certain level without causing addiction or something like this. I think, reading that's what they're trying to do. My problem is in each and every proposal like this, you have to have a very good body of literature to back you up that something like this exists. And rather than pulling it out of thin air and say, hey, I think this might work, but the price for this is killing people, subjecting them to risk of death, especially with the exclusion criteria that they propose, and we can come to talk about this.
Sure.
I don't think this is sufficient to unreveal potential risk for arrhythmia. Doing an EKG and a stress test, there are lots of people who can pass through this and still can have a substantiated risk of arrhythmia. And that's why lots of people can be addicts for years, then they die from an overdose, because nobody knows at which point in time you're going to hit that target. And lots of people, even the addicts themselves, who are very good at telling how much they need every time, they can mess it up.
Okay, very good. So going back to your question and the topic you've both been talking about, so what you as the IRB might be concluding now is you want to send this back to the researcher to expand the discussion in the protocol about more details about where is this going to go in terms of, are there other medications out there, other drugs that are currently being studied that might be used in these subsequent studies, together with the information from this study. Perfectly legitimate for you to be concerned about. Excuse me?
Specifics would be helpful. Yeah.
Specifics would be helpful, absolutely. And this is what IRBs will often do. Flesh out this part of the protocol. Give us some sources, some other articles out there that we want to know more that, given the point about the concern about the risks in this study. And now it sounds like we should probably now look at those risks and actually ask ourselves, are the risks, you're certainly concerned about the risks, are the risks appropriate? But yep, fleshing out the protocol, asking them to expand one background section or any section, perfectly appropriate. So people okay with the design? Basically, we know the basics of the design, the randomization each of these people are going to get, or do you want to go?
I just had some concerns that this.
Let's get you the microphone, yeah.
Sorry, I just had some concerns that the psychological component is it's kind of made a big deal out of in the introduction, but the actual cognitive testing and psychological assessment is not addressed at all in the proposal itself, which I think is a problem. I would ask them to delineate exactly how they plan to assess cognitive and psychological effects instead of just saying, well, we're going to do that.
Okay. Yeah, no, if it didn't say anything about that, that certainly sounds like a great point. Again, you'd want to go back to the investigator and say, clearly the psychological aspect of this is a very, very important part of what you're studying, yet you haven't given us enough details about what you're actually measuring and how you're going to measure that accurately and what history there is of your having an appropriate test. Good.
My only other concern was that they stated that there's 48 hours between doses. I don't know what the metabolism of cocaine is and if there's any potential lingering effects if that's long enough.
Right. No, very good point. Clearly you want to make sure you're getting different effects from each particular dose and right, that it has all washed out. So good point. Can we pass it backward?
I can do it. Have a loud voice.
Yeah, but they're probably not going to pick it up on the video.
Looking at the inclusion criteria and the exclusion criteria, it's extremely complicated, and I'm not sure how you would do all these things satisfactorily with your group of volunteers. I mean, there's 3 pages of extremely complicated technical testing that has to be done. And short of incarcerating these people, I don't know how you would guarantee that they adhere to these things.
Oh, well, okay, so maybe in terms of just understanding the procedures of the study, what is actually happening in the study? Would somebody like to comment on maybe the incarceration aspect of it? Anybody back there, or we have volunteers up here?
Well, they're supposed to be in, I believe, in an institution for 4 weeks, so not leaving the. But going back to that comment, I actually think it's very much necessary to do halters, to the echoes, EKGs, neuropsych, imaging, carotid Doppler, transcranial Doppler, because we are giving sympathomimetics to these guys, to participants, which means, yes, we can induce possible arrhythmias. So knowing whether they have any history of arrhythmia, and if we do find it, to direct in that proper direction is what's needed. So I don't think it's actually broad. I don't think it's unnecessary. I think it's very much necessary.
Okay, so, and yeah, more.
But there could be a concern of, can they reach that many people? Because, I mean, I know it's only 20, but are they going to find this many cocaine addicts that are healthy and willing to do this study? That could be a problem.
Okay, so we're now kind of fleshing out the risk aspects, right? We start out with a concern, maybe this study is too risky, and now we're seeing, well, actually a major part of this protocol is doing a lot of testing on these people to somehow, get the people that are actually healthy cocaine addicts, which of course probably is a substantial challenge, because by and large being a cocaine addict doesn't exactly put you on the healthy side of things. But I take it to their credit, right? You're indicating this is really, really important. They really don't want to be there and causing some person to have the arrhythmia or heart attack or whatever horrible thing could happen to them. They actually want this to be, that they've done the right things in terms of making sure they're not doing bad things to these people, given the starting point that obviously getting cocaine, pumped into you is not a good thing in general.
And on top of that, they actually have specific rules. If your blood pressure goes 140 over 90 at any point before they give the infusion, or even later on to exclude them if your systolic is above 200 and diastolic above 110, or whatever your heart rate goes up to. So it's not, they're just going to be randomly. They actually are having specific indications, like when we're going to do it, how are we going to proceed, whether to give it or not to give it. So I think that is very much necessary if we want to jack up somebody's blood pressure. Okay, let's make sure that he can sustain it and not just kill you because of the blood pressure and give you a heart attack or a stroke. So
right. Okay. Good. Right. And you had noted earlier, I think, right, in terms of the doses and the infusion rates are all things that there is other evidence out there. Now you could ask yourself, were there enough other studies that did this? But they made it clear that they are not using either doses or infusion rates or combinations of the two that have not been done previously. Because certainly could be in a lot of studies you're doing something nobody has done before. They're explicitly saying enough earlier studies have been done with both these doses at least as big as these, if not greater, and at infusion rates that were even perhaps faster.
Yeah,
and
and to add to
much.
that, they also say that in order to be a participant, you have to have used the highest dose before. So it's not like, oh, this is the first time for you, we're going to be giving you a high dose. This is something that you have done before.
Okay, another important point. And maybe we want to say a little more about that, because this gets sort of to what is the baseline in terms of determining risk and relevance to this criterion in terms of what the risks are. And you may recall the discussion yesterday about ideally you want to kind of do procedures on people who perhaps might otherwise have been having this procedure done on them for some other purpose. You want to comment on any of this? Because we are getting to, this is an unusual type of study, but this does tie into, you might ask yourselves, why they designed it, who they're doing this study on. How does that tie into our discussion of risk? So,
I was just going to say that I would be worried about this population there. The value, excuse me, of the data that you get from them. whether or not they're going to be good historians and give you valid answers to your questions about a lot of things, your family history of disease. They may not know their history, or they may, tell you what you want to hear, especially if they're very motivated to, once they see the informed consent and they see how much money they're going to get, and that you're going to be giving them cocaine, which is their drug of choice. And so I think you're going to have a lot of trouble with that. And so that increases the risks to them because of that.
No, it's a very good point that in terms of the information they're providing to you, they may perhaps be trying to deceive you. So that might put some of the weight on the aspects of the study in which they're doing all the subjective stuff and doing a bunch of lab tests and other things. So at least a person may come in and say, I'm incredibly healthy, or whatever it is, and that's why they're spending a lot of time and effort to not just accept their word, perhaps, to the extent you can actually determine any of this. And you wanted to say more?
Very valid comment, and I agree with that to a degree, but at the same time I don't, because what would be the alternative? Putting subjects that have not been exposed to cocaine, and let's say I decide to participate, I'm not an addict, which means that my addiction pathways in the brain have not been altered as somebody who is addict, which means that I'm not going to respond the same way that the addict would, which brings us to the point, then why do this research at all? Because we're not going to get what we're really looking after, hence no ability to help somebody who is a cocaine addict.
Okay. Others on this point? I mean, we do sort of have, and maybe let's just wrap it up in terms of tying it again back to the risk levels, and we're back to kind of ideally, in terms of truthfulness and that sort of thing, this is not a population that may be all that truthful, but in terms of the actual information we want, if the goal is, again, getting information that are relevant to the responses in cocaine addicts, presumably you want a cocaine addict. And how does this finally tie in with, several of you have gotten into the issue of the risk level for these people. What other fact that we haven't talked about that's sort of either an inclusion or an exclusion criterion are they looking at in terms of looking at what happens to the people in the study versus what would have happened had the person not been in the study? Because again, we had our criteria here. Well, we didn't really answer what the level of risk is. That's a little tricky. What does a PI consider a level of risk to be? But how do we even figure out what the risks are to these people? And this gets to sort of perhaps a before and after thing. What would be the state of affairs if the person wasn't in the study? And that's often exactly the analysis you want to do. You have to be very explicit about that analysis in terms of the IRB.
Right. So their protocol is to have injections every 48 hours, only Monday through Friday, so a maximum of 3 injections a week. And their inclusion criteria is somebody who does at least 3 injections a week on their own and at higher doses than anything that they're giving. So theoretically, in the real world, not part of the study, they would be putting themselves at cocaine death risk or all the other fun things that happen with cocaine in an unsupervised place. So they actually may be safer doing this in the study where they can be monitored medically.
Yeah.
You can make that argument.
Yeah, no, that is an argument that they actually sort of are making, and I suspect people who do these types of research are in fact making those arguments. And one other criterion which is related to all this is an exclusion, that it can't be that this addict was trying to do what in terms of
seeking treatment. So yeah.
Right. So they're very explicit about that. If you're actually somebody who's trying to quit the cocaine to fight their addiction, you shouldn't be in this study, and they're explicitly saying they're not going to allow you to be in this study.
And
so it's sort of interesting in terms of that.
Pregnancy is also an exclusion criteria, whereas somebody on the streets who is pregnant may continue anyway.
Okay. Okay, so there are clearly a lot of challenges here, as you've indicated, in terms of people lying, and we'll flesh out a little more about this as we get into kind of how are they going to recruit the people and what issues might be raised. But in terms of the risk level, right, we've heard the argument here that, well, maybe you're actually, in a strange way, helping these people. you're going to get people, and assuming, again, they haven't lied, they actually are supposed to have been using more cocaine out on the streets than they're going to get in the study. And yeah, you're going to be in a monitored environment. You're monitoring them every which way. I mean, in terms of somebody actually using cocaine, you can't be in a more ideal scenario in terms of they're checking things and having the crash cart there and everything else available in terms of actually treating any of the bad physiological outcomes. Now, again, we're back to kind of, right, how much are they lying? In general, I assume the researchers who do this kind of research know other colleagues, they know the populations out there, so they have ways of kind of being, you know, fairly secure that the people they're getting are in fact heavy enough users. They know the places probably where you're going to find these people and the communities they're part of. But it is an interesting take in terms of this study, because this would be a big issue for the IRB. You know, right, injecting people with cocaine is kind of not a benign thing. We talked yesterday about kind of, you know, risk versus benefits. We haven't gotten to the benefits side yet, but certainly you don't want to kind of be exposing people in a study to even a non-significant risk of death. That's certainly not a good thing even for cocaine addicts, and so you want to kind of be fairly comfortable, right, that you've designed the study correctly and you have the right patient population. And here you do have that argument that these are people who hopefully, not that hopefully is the right word, would have actually been in a worse circumstance had they been on the streets, because they would have been using. They shouldn't be in the study unless they were already using, and probably there are ways of getting a sense that they already are users. And even if it didn't happen, you might be able to detect that on the first dose or two, because what are they doing in terms of the actual study, in terms of how they're giving them the doses, right?
They're starting with lower doses.
Exactly, right.
And
so
monitoring them and making sure that they don't have toxicity before they increase.
So it's possible that if somebody was not a user or was not using these doses, something might happen even at the low doses. They would pick up that kind of, this person was deceiving you, whatever it is, and shouldn't be in the study, and you could then exclude them fairly early on. So these are all the things they thought about. And again, even with all that, this is not to say this isn't sort of one of the more controversial types of studies that you might want to do. Anything more about the risks? Okay, so are you kind of inclined to say in terms of risks that this is on the reasonable side? Remember, our standard, we have to compare the risks on one side, and they have to be reasonable in relationship to this sum of the other two things. The benefits, if any, to the subjects, and sometimes there may not be any to the subjects, and the importance of knowledge that may reasonably be expected to result. Let's see, any aspect of that? Well, we didn't get into C, which is there a prospect of direct benefit to the subjects? That's probably an important thing for us to kind of say something about. It's part of our equation. I mean, it could be that you're comfortable with the risks versus the other side being the sum of the benefits and the importance of the knowledge. So you might conclude this is an important study. We want to be able to help, you know, people kick their addiction, and therefore even if there were zero benefits, the balance would be appropriate. The risks would be reasonable in relationship to the other side of the equation. But it's certainly good nonetheless for us to think a little about the benefits, because if you concluded there were a lot of benefits, it would actually make it even easier for the IRB to approve it, right? Because it would be more reasonable. Do you want to say something about the benefits?
Well, it says in the informed consents that there is no direct treatment benefit, and at the end of the study, they will refer you for appropriate treatment if you want to get treatment.
Okay, so they're going to refer you at the end of the study. Should we consider that to be a benefit from participating in the study?
Not really, because they will also do that for you if you're not interested.
That sounds like a reasonable argument, right? Yeah, we shouldn't kind of if the right thing, certainly for somebody who actually wanted treatment, and this gets tricky because the starting premise here is they're only enrolling people who said they're not trying to kick their habit. But let's assume for whatever reason you had somebody who might want to kick their habit. Yeah, you shouldn't be conditioning being in the study based on, we'll give you the names of nice place to get treated after you've been in the study and you've done the 4 weeks and you've done everything we want you to do. This gets back to, remember, we have the undue inducement and coercion. They're sort of different concepts. Coercion is when you're threatening to take away some right that a person has and using that as a way to get them into the treatment. So sort of threatening a bad thing. Undue inducement is just the opposite usually. Inducement is you're promising too much of a good thing to get them into the study. So, for example, I'm going to give you all this incredible free medical care, and we know you're really poor, you're a street person, you have no insurance. That's an inducement issue. It's not a coercion issue. On the other hand, if you're sitting there knowing there are a bunch of programs out there that will be happy to enroll this person and help them quit their habit, and you say, if you go into the study, we'll give you this wonderful list at the end, you're kind of taking away a right that they already have, that any appropriate care provider, including researchers, probably would fit into that category in the sense that, again, you shouldn't be, deceiving them in some way. So, did you want to?
Somebody free cocaine might be an inducement.
Well, okay, so we're getting into, so this is related to our point about the benefits from being in the study. So we talked about, telling them about programs, probably not a benefit largely because they've already said we're not trying to enroll anybody who wants to quit. So they should immediately on the first discussion not enroll the person and say, here are the programs. So are there any benefits in this study? And you're doing an appropriate thing. You might want to look at not just the protocol, but the consent form pretty much has to have a section discussing benefits. So that gives you a hint on what the researchers think might be the benefits. So others want to get into sort of more in the benefits?
I think at the start of the study, they were giving a chance to test whether they have the HIV antibody. Maybe this is a benefit.
Okay, now that could be a benefit, right? Exactly. This gets into what are their options outside of this and whether or not there's free HIV testing elsewhere. But it certainly can be a benefit that they made it easier for you to get tested for HIV instead of, getting it somewhere else. Absolutely. Good point.
Right, so I think, any of these studies have this benefit to bring people into the system, if you wish. Even if there is some sort of an incentive which will get those patients to come and register, eventually you're giving them some sort of a physical that otherwise they wouldn't have. Cardiac risk stratification, very important for people who are cocaine addicts. HIV stratification, which psychological support, if there is any, because there's supposed to be some, which can bring them to attention. Right, they could be all articulated with certain clinics in their community that deals with addiction on and off, but that's probably a good chance to get them to catch up with some of their health issues. So it is a potential benefit, although I don't think it should be the benefit from the study, because the benefit should be potentially treating them from their addiction, but I think it's difficult to get out of this study in particular.
Well, and again, we're back to what their recruitment criteria are.
Correct.
If you have any desire to quit, they're not wanting to enroll you. Mm-hmm. So I think you're legitimately raising, all of these things relating to they're going to be off the streets for 4 weeks. They're going to get a ton of medical tests. This may be information that is directly helpful to them, or as you note, they now have a connection with the medical system, and that may be something that was hard for them to get. All of those things are very legitimate benefits that the IRB can recognize in terms of their analysis. What one thing sort of is described in part of a consent form have you not raised in terms of it possibly being a benefit? In terms of the addict, what might they view as a really good thing that's going to happen to them in this study, even beyond this medical care and being off the streets and everything? Right, they're getting paid. So you want to comment on the payment? You? No? You're just pointing it out? Okay. Anybody want to say anything? I mean, that's an interesting issue. How should we categorize the payment? Because from the viewpoint of the addict, my guess is they would probably, what are the good things for me in terms of being in the study? Yeah, I'm off the street. I have a warm place. It's not going to rain on me. You know, I'm going to get meals, which, you know, whatever it is. And I'm going to get a bunch of money, which could be, we talked earlier. How much money are we talking about? 1,300
Like 1,300.
Okay, I mean, that's probably for your average cocaine addict, that's a nice chunk of change. So should we consider that a benefit? And probably the cocaine addict probably considers it, you know, if you ask him, okay, give us a list of the benefits to you from being in this study. Hopefully we could all agree they'd probably put the money somewhere on there.
But is it smart to actually list that as a benefit for them? Like, would there possibly be a way that we can put it into the consent another way?
Okay.
Like, you know, later on in that listed as a benefit more so, or even spell out how much they're going to get? Do they have to know that?
Right. So you're raising an interesting issue. These are great issues the way you phrase it, right? Should we categorize it as a benefit in the consent form? And the separate point, very interesting, should you somehow not actually spell out how much money it is and that sort of thing? Okay, very interesting. Others want to
So that's
chime in on
actually
that.
addressed in the training for IRB and the standard rules, that money and compensation is not a benefit. It has to be decided on as far as whether it's a coercion or an inducement problem, where with, you know, drug addicts it's a big problem. But it's definitely not ever considered a benefit.
Okay. Now, did you want to say?
I did, actually.
Yeah, sure.
I was just going to say it's only considered a benefit in this scenario because you're talking about potentially people who are really socioeconomically disadvantaged. $1,400 can be made at minimum wage. They're asking for a month of inpatient. It's only an advantage because of the population that you're talking about.
But they'll use it on
Well-
drugs, so it's maybe not.
So I guess
They'll use it
I don't
on
think it's
drugs,
fair
okay.
to call it a benefit, because if you were anything other than homeless, it's not that much money for a month of your time, I guess is what I'm trying to say.
That's the point. So it's not a benefit monetarily.
Yeah.
Okay, and you wanted to say more, right? Yeah, let's.
I think that even if we were just to tell them there is compensation at the end, that would be enough to lure them in. But just to let, you know, even if we let them know how much to this capacity, that could already have them setting up things, you know, stuff for when they get out.
Yeah, okay.
And-
So let's flesh this all out a bit, because you raised really good issues here, and you're sort of talking about things that actually are complicated issues in terms of how IRBs talk about this. I think from the viewpoint of the subject, you should look at it separately from the viewpoint of the subjects and the viewpoint of the rules. From the viewpoint of the subjects, exactly what you're worried about, it is a benefit to the subjects. By any standard, this is a lot of money to these subjects, and they would view it as a good thing. It may give them an option on getting more cocaine, but once they're on the streets and they're an addict, they need to get more cocaine, and they may have to do even riskier things to get the cocaine if they didn't have the money in order to purchase it. So I understand your desire to kind of not categorize it as a benefit in the consent form when you talk to them, and I think consent forms by and large will not put it under the category that says benefit. They'll put it under the category often that will say compensation or will you be paid or whatever it is. Normally you don't hide it from the people. I mean, the bottom line is if you're paying this amount, that's part of your study, and you should have a legitimate reason to pay them. And you do have the issue of, is this undue inducement? And if it is undue inducement, then you don't try to hide the amount you're giving them, because the reason you're giving them the money in the first place is because you think it is appropriate and does some appropriate thing for you to get that money. But let me, before we go on to the other aspect of it, I just want you to contrast that with not looking at it from the viewpoint of the subject, because from the subject, in their minds, of course they're considered as a benefit. But from the viewpoint, you're now functioning as an IRB, you're looking at a rule that says compare the risks to the subjects to the benefits to the subjects plus the benefits to society from the knowledge. If you included money on the benefits to the subject side, what would that mean in terms of approvability of studies? It would then mean that any study would be approvable as long as you pay the people enough. And as a society, we think that's a bad thing. We don't want to say, you have this incredibly vulnerable, population. We're just going to up the payments such that this benefit element will outweigh the risk side. We think that's bad. That's eliminating the clearly paternalistic elements that we think are appropriate here. And therefore, so notice that's just the way the rules work, and I think a lot of us would say that's a very appropriate thing for the rules to work, that the IRB, as you're now looking at the risk versus benefit balance, you should in no way include the payment on the benefit side, even though from the viewpoint of the subjects, of course they see it as a benefit, and they're correct in seeing it as a benefit to them. But in terms of determining that the study is approvable, you, the IRB, cannot look at it as a benefit, because that would be problematic in terms of making virtually any study approvable if you pay enough. It's like was it Robert Redford? So in one of those movies where the guy is trying to seduce somebody else's wife, and then is sort of figuring out, well, I'd like to sleep with you tonight. I'll give you, $10,000. And she says, it's evil of you to even suggest this. I'm very rich. I'm going to give you $1 million. And he says, oh, then they start thinking about it, whatever. I mean, that's the legitimate problem. And you're already raising this issue in terms of, So there's just different ways that this question is being impacted in terms of the actual IRB approval rules versus a separate issue, which is, this undue inducement. Do you want to say more? Or no? Okay. So anything more in terms of the compensation?
I was just going to say that in addition, it kind of points to this population as being a vulnerable population, because this amount of money does correspond to quite an inducement for them.
Absolutely. Undue inducement issues are very, much greater, exacerbated in terms of, people who are poor, people who don't have other sources of income. And I know you wanted to, can we get the microphone over there? This is a very big deal in terms of the sort of things IRBs worry about. It doesn't have to be a huge amount of money. And the undue inducement issue, again, it gets back to kind of, you're worried that the amount is so great that it's going to get these people to not look realistically at the risks they're exposing themselves to. Now, which may not be the case here, because we've concluded perhaps they would have been busy even using greater amounts of cocaine.
Isn't there a chance that the people can also be from wealthy? They could be from a wealthy family where they're just users? Because isn't cocaine expensive to buy?
Yeah, it's an interesting issue.
I was just wondering.
Okay, sure.
So, the money, maybe they don't even care about the money.
Yeah.
It may have just been the fact that they're getting free cocaine.
It could be, yeah. No, it's a good point.
If they come from certainly wealthier.
Right, yeah. Now, I don't know how many of your average cocaine users out there actually are in the wealthy, chunk of society. But that's certainly true. The sort of paradox about, how do these people who generally, because of the effects of cocaine, end up not being able to keep a job, and their life goes downhill pretty rapidly and everything. But absolutely, you could be, in fact, in terms of being healthier and everything else, that would probably be an ideal chunk. You don't have to worry so much about the undue inducement. They're probably healthier. So if you could find some really upscale lawyer who just has this cocaine addict but is making mega bucks or something and is still keeping his job.
Because the guy from Wolf of Wall Street was also a big cocaine. He did a lot of coke too, but he had was able to establish his business. I was just wondering, it could be an upper class person too, along with lower class.
No, that's an excellent point. I don't know anybody who's more expert on what your average cocaine addict is like or something. And but very, very, very true point. We have somebody way in the back there.
For myself, I think the real benefit for them that ก็คือ they can use the cocaine and save life, not do overdose, shot himself and drop dead. That is the real benefit for them.
Okay. You know, absolutely. Right. They're getting the cocaine and everything. Absolutely. Yeah. So, okay. Anything more on the benefit side? So we're sort of seeing, can we pass it down here? We're seeing that there are a bunch of benefits in this study, not the money, but everything else we're talking about here, probably are legitimate things that the IRB can consider as benefits.
Just additional comment. Isn't it the final amount, I think the 1,300 or whatever it is, if they actually go through the study, which means if somebody who wants to participate but it's disqualified wouldn't even get not even the third of it or whatever.
Yes.
So
Yeah.
what I'm trying to say, we're spending so much thought on the amount, which is to begin with not that high unless somebody really is homeless and vulnerable, etc. But that doesn't necessarily mean that they would get that amount, which something.
Right. Okay. So you're correctly pointing out it's sort of a pro rata sort of payment scheme. You're not going to get the full amount unless you participate in the whole study. And I don't know if you're already saying this. Do you have to participate in the whole study to get like part of the amount, or I mean, is it? You will. You get partial payment. Okay, right. But so everybody clear? You actually, that is pretty much. It's not a black and white requirement, but pretty much in terms of what the rules are. Remember, we were talking about the possibility of coercion. And so if, in fact, you did 90% of the study, but the rules were you do not get any money unless you complete the entire study, by and large, the rules will say that is not an allowable payment scheme because basically the person actually did almost all the work, and let's assume 90% of the study is over, and they finally decided, gee, I really don't want to get this last dose of cocaine, but they're looking at it and saying, if I do, I'm going to get the $1,300, and if I don't, I'm not going to get anything. So basically, that is almost, coercing them in that they're losing the money they should have earned by the 90% of their participation. So be aware, by and large, this is one of those issues that kind of you learn about in terms of being on an IRB. By and large, the rules almost force you to do pro rata payments, that as long as somebody is willing over time to put in part of the effort toward participating in the study, they should be earning an appropriate amount of money for that portion of the study. That gets into what's appropriate, depending on how your payment amounts may be related to actual exposure to risk or the time and effort or whatever it is. But you can't sort of create an all or nothing payment scheme, because notice that would then raise this coercion issue, because basically the person pretty much put in the time and effort. Imagine it wasn't in a study, but the guy was working for you for 3.5 weeks, and they then quit or something. You can't say, I'm not going to pay you anything. And in fact, many employment rules will say the person earned 3.5 weeks of pay, you have to give it to them. This will create coercion, because remember, you're taking away a right they have. Well, basically, they've earned the 3.5 weeks of payment. It would be inappropriate for you to basically create a non-pro rata payment scheme, I think.
I just had a question about the payment, because in the informed consent it says that they will give you the payment, but you have to not show any signs of having any being like drug abuse, or I forget how they phrase it. If you show any evidence of being impaired by recent drug or alcohol use, and then they
at
will.
At the time that they pay you, is that what they're saying?
If you come back for the payment, then they will hold the payment till a later date. And I just wondered if that was something.
So why do you think they're doing that?
I guess so that you don't. I'm not really sure, because if they knew that you were not seeking treatment when you came, so. Maybe you didn't. Yeah, maybe you didn't give them the payment, but that's the only.
Right. So you're raising the issue of their being impaired. You want to get? Yeah. Can we get your colleague on the IRB here?
I was just thinking that there's a vulnerability aspect of it as well. If you're impaired, then you may not, you're going to take the money. If it's just not, you're not in your clear mind. That's what I would think. So they're trying to abstain from giving money to someone that is impaired. So.
Okay. And did you want to say more?
I was just wondering, was a hidden benefit in here, even though they say they don't want to have volunteers that want to quit the addiction, is to actually teach the addicts, because they're getting all these health assessments and they'll be able to view how their health's changing with the cocaine. So isn't it kind of hidden to try? I just feel like it might be hidden to try to get the addicts to actually want to quit.
Want to quit?
At the end of the study, after they see the effects that cocaine has on them.
Good. No, that's interesting. I don't think they say that, but I think that would perfectly be appropriate if you actually said that and the IRB was thinking about that. You've sort of deceived them a little, because you start out saying...
Because then they wouldn't use the drug when they come to collect the money. If they saw if they were smart and they saw all the effects it had on their body, they would be like, oh, I should stop using this.
Yeah. Okay, now that's a very interesting point. Okay, good. So getting back to the final, right. So they're basically, it sounds like they're just saying that we don't want to pay you. We acknowledge you want the money and you want to spend it appropriately. If at that point you're not with it enough that maybe you're going to get robbed or something else, they're just going to be protecting you. The same way, hopefully, the bank, if you're kind of totally out of it and you're trying to withdraw all of your savings, hopefully the bank might kind of say, we don't think you're actually making an appropriate request. Come back tomorrow or something. So it sounds like they're actually just being a little paternalistic. They're not in any way not wanting to give you the money. They're actually wanting to make sure they've given it to you at a time when you're going to take care of the money and do what you, when you're in your better mind, and more competent, are able to think about it. So, but an interesting take on that, yeah, because you want to ask yourself about all these provisions of it. And
just one question. I'm not certainly experienced in this, but isn't it true that different people, depending upon their length of use and so forth and frequency when they are on their own, would be affected differently by the doses? And how do you end up having any kind of data that you can get a conclusion from?
Okay, fair enough point. Others want to comment on that down here?
I think it's a legitimate point, but I also think if you look at the articles where they're saying that the risk is minimal, that it actually isn't, that they had to disqualify 10 to 15% of patients in one study for abnormal Holters within 9 hours of use, but there's nothing suggesting that they're going to do the Holter on the incoming subjects within 9 hours of use. I just feel like I feel like that's a legitimate point of, in terms of benefit even to society, are you going to get anything usable out of this? But I also feel like the risk is downplayed a little bit in the study itself.
I think you're also asking about tolerance differences within people who used for different amounts of time, and that's the beauty of the within subjects treatment. Design is that you're going off of their own baseline, so you'll see a difference in magnitude that may be more useful than just comparing a group of people that have a different tolerance level.
Okay, but you're raising a good point. We were concerned on the low end that you wanted people who had actually used the stuff enough, but you're sort of suggesting maybe in the higher end, if there's a big spectrum of different amounts of cocaine that these people are regularly using, maybe it's going to affect the data. And so your point is, if you could do the comparisons within that one person, as they're their own comparator, maybe that will eliminate that. Or maybe there aren't that many differences once all of these people are using a certain amount of cocaine fairly regularly. But all legitimate points that relate to, is the scientific design of this study appropriate? All legitimate things for the IRB to be worrying about. Did you want to say something?
I was thinking about the fact that while the subjects are out on the streets on their own, they may have different regimens throughout the day, what they eat or when they eat or something. And when they're here, they're restricted to these rules.
They
so, I mean, behavior-wise, could that possibly have like an effect. You know, you're giving these same amount of doses here, but you're really not living the life that you would be living, you know, when you're not in this facility.
Sure.
So that could kind of take away from the behavior.
Yeah, but it's an experiment. You're trying to look at a particular variable, so you have to control the confounding variables. Sorry, I'm holding it. That's totally true, but it's back to doing clinical trials and controlling for confounding variables and making sure that you're actually studying the variable that you're interested in, which is this interaction between dose and infusion rate. And so you need to control all the other things so that you have actual data that isn't so variable that you lose any signal.
Yeah. So
it becomes a generalizability issue.
I mean, both of you are raising a great issue here. And you wanna...
I was just going to ask as well. So I was thinking about, in terms of the inclusion criteria, I mean, you're basically, like you said before, looking at a very healthy individual. So could you you can't really generalize these results into the population as a whole, because the odds that all cocaine abusers are healthy is not a good, it doesn't make sense, I guess. So I don't know how you would, I mean, if it was used as like a baseline study and then you extracted from there, it might, but it wasn't necessarily clear, and I know the research is very minimal.
Yeah, I mean, you're basically doing exactly the debate that is very active these days in terms of how we design clinical trials, right? We talked a little bit about it yesterday. You try to standardize things, okay? If you're actually in the real world and not in a research study, well, this is, of course, taking cocaine, which is a different thing, but you need standardization, or at least standardization helps you just compare the two arms to make sure the only difference is your actual intervention. But the more you standardize, the more you actually make it harder to say the results you're going to generate in this study are in fact going to be applicable to people outside of a research study. And this is a huge debate right now in terms of, I assume the rest of this course kind of covers this, right? In terms of, there's a big push for pragmatic clinical trials these days, with the notion being that in a lot of clinical trials, we've restricted the enrollment criteria so narrowly that all we do is, yes, we answer a question, but it may be on a patient population that has no relationship to the actual people out there. And people actually don't have the answer right now in terms of, should we be doing a lot more pragmatic trials? And the more so-called pragmatic trials, just you have far more relaxed recruitment criteria. Take a much broader group of people, but then the issue that raises is, are you less likely to actually get a result because you got all this noise, and maybe you need massive amounts of recruitment and massive, numbers of subjects.
Right, but if we go back to their original kind of benefit of the study in general, they're trying to come up with something to standardize experimental design for treatment studies. This may be exactly what they need in order to have a standard protocol for a treatment set so that you can actually use good information in the future. This wouldn't necessarily mean much to the general population until you get to that point, and those can become bigger, more generalizable clinical trials.
Good point.
Yeah, I have a question about why they exclude people who are seeking treatment. Because for benefits, you can think from two perspectives. One is for the participants, and one is for society. And if their results support their hypothesis, and which means that this may be a treatment. But I think maybe we should change our study population to those who are seeking treatment, because they will benefit more from this study.
Well,
because you can now say that people who do not seek treatment benefit from this, what we do in this study, equals to those who do not seek treatment. And those who seek treatment do not equals to those who do not seek treatment. So the study population and your target population is different.
So you want to have them enroll the people
we want to treat people who they want to quit the addiction.
Well, they are right, but the goal of the study, right, is this study is just going to generate information that in the long-term future will eventually be helpful in terms of creating other drugs or something, or knowing more so that we could treat people. But in this study, are they treating the people?
Yeah, I think maybe we should include those people who seek treatment
Because what would be the alternative for those people? Instead of being in the study, what might they want to do? Or what might the researchers think is the ethical obligation? Somebody's sitting in front of you and they say, by the way, I really want to get off my cocaine habit. So, okay, so if they enroll in the study, you're now going to spend the next 4 weeks making sure they keep getting cocaine every 2 days. And you understand the dilemma in terms of the researchers thinking that somehow seems to be a bad thing. Why not take that person right then and say, I'm going to find you a spot. Now, this is a trickier thing in terms of whether or not there is a spot right then. But you understand the tension is that if the person really wants treatment, we don't want to be giving them more cocaine. We want to actually get them off the cocaine as quickly as possible. And I assume that's what actually happens in the treatment facilities, right? You will make sure they don't get any cocaine, and you will do what you can to kind of tie them down or support them or whatever as they go through withdrawal and that sort of thing.
Yeah, I understand that. But I mean, for target population, you want to help people who want to quit addiction.
Right.
So you do experiments with those people. Maybe you can benefit more to the society.
So
What if they didn't get, let's say they get a dose that they're not used to, and meanwhile you give them a heart attack or a stroke, or you kill them in, is that worth? Do you really want to treat them that way?
yeah. Well, and we're trying. Let's assume we're really trying hard with all of these people, even the people who end up being in the study, right, to minimize the likelihood of this bad thing happening to them. It's probably more, we're back to kind of they want to quit. And if your starting point is that they want to quit, why enroll them in a study in which you're basically going to give them more cocaine, which is the source of their problem in the first place, and they're saying, well, I don't want to be taking cocaine.
Isn't the rationale of the study, though, that a maintenance dose of cocaine would help you quit? Wasn't that the rationale of the study?
Okay, yeah, it is in terms of, right, in the future, that if we titrate the dose to the right amount or something, you could do that. But I don't think they're claiming that being in this study is somehow good for you if you're currently a cocaine addict, that you're going to be better off at the end. You're going to be better off because you got certain benefits, right? We talked about that. Health information, part of the healthcare system. You're off the streets for 4 weeks. But you're going to get into this complicated balancing act that I suspect they would have a hard time saying this is good for somebody who wants to quit because you've intentionally given them more cocaine for a month when you could have started on day 1 or 2. And probably realistically, that would have to be based on an assumption that, yes, there isn't a 4-month waiting list to get into a good treatment program.
It's not standard of care. I think that's the...
Okay, right. It's not standard of care to be giving cocaine to somebody who wants to quit. That probably would be the argument. You want to give it?
I mean, people want to quit cocaine. They must have a process. You
Right.
choose those patients. Their use of cocaine is less than what you will use in this study. Is that okay?
So you're saying they started out using, what, a higher dose than what they were getting less in the study than they would have gotten otherwise, or?
Yeah, maybe people, they want to quit.
Right.
But at that time, they also use cocaine.
Right.
But their dose is higher than
Right,
what
right.
you do in your
Right.
study. So
Okay.
can they be the participants?
Yeah, no, that's an interesting, so you're saying they're better off and they're getting less cocaine in the study than they would have outside of the study. Wait, you see others behind you.
I think the person who joined to this study or participant to volunteer to be in the person in this study don't want to quit the cocaine. They want the money.
Yeah. Well, it's a rule of the study that you
Yeah.
actually have to not want to quit. But
then my question,
we're raising an interesting question about whether or not you could have changed that exclusion criterion and enrolled
But
somebody who wanted to quit.
my question is the study that give money at the end of the study for the participant in the consent form of that one, what kind of the writing in the consent form for the person who tried to participate to this study. Consent form to give the money at the end of the study. Quite interesting.
Yeah. Okay.
I had just one quick thing, jumping around, I'm sorry.
Sure.
When I read this a little more about the process, they say that people will get a daily morning experimental session where they will receive 1 dose of intravenous cocaine or a placebo. Isn't a placebo usually anonymous? I mean, wouldn't somebody realize that they were not getting high and getting cocaine? What's the point of a placebo in that?
Baseline. Physiological response baseline.
Psychological,
okay,
creating.
Right. Yeah. I mean, you're going to get a baseline, and you're going to see, and they're not going to know which dose is the placebo, and depending on how used they are to relatively high doses of cocaine, it could be the lowest dose in this study will be so low that it'll be like nothing to them.
Placebo doesn't mean none at all.
No, placebo will be none at all, but it could be that dose, from the viewpoint of some of these people who are really heavy users of cocaine, and to be in the study, you should be a fairly heavy user because you would have had to be regularly using a dose more than the maximal dose they're going to be giving you. So, for example, getting the lowest dose at the lowest infusion rate, the lowest of the 9 possibilities, it could be that from your viewpoint, that's like nothing. For the really heavy addict, they won't even respond to that. Maybe you wanted to comment on the psychological aspect of it.
Yeah, so just for the placebo story, placebo is not nothing. Placebo effect is there. So there's something called the placebo effect. And that is, in the brain, there are certain areas that light up in functional MRI, so there is an effect to placebo. But to her point, I think it's quite interesting that eventually, to think very abstract way about the concept of the study, the potential target group for that intervention are people who want to quit cocaine. Yet the experiment cohort are people who don't want to quit cocaine.
Right.
So I think eventually it should be listed as a limitation that the study group was not the intended to treat group. And I think that is quite it's an interesting point
it is,
to be made, because you want to use this, and one point to be made is what the difference between two groups. I think the psychological element here is different. Whether you want to get high when you don't want to quit and you get high when you want to quit is probably different parameters, and these doses and infusion rates can be affected by this psychological element because you're measuring a psychological endpoint here.
No, that's a good point. Okay, so this is a different patient population, and maybe it actually affects what you're measuring. An excellent point. Yeah, so I mean, a lot of this is very complicated, and those are legitimate scientific issues. Yeah, so more on this.
Procedural question.
Yeah, okay, let's get you the microphone.
Hi.
Sure.
Sitting and watching it all from
Yeah,
last
you're
row.
way up there.
Yes, and it's all very interesting and exciting, but I'm coming from like management point of view.
You may want to hold the microphone a little
What
closer.
we're doing now, we're, I guess, playing an IRB meeting, right?
Absolutely, yes.
Is there somebody who is actually making notes for future stipulations?
Oh, absolutely.
At this point, I'm completely confused. Are we approving this protocol? Are we disapproving it? Where we're leaning towards? Because it's such a free-flowing discussion about like general issues of clinical research.
Yeah.
It's perfectly fine, but I just wanted to point out, what's our goal here? Are we deciding the fate of this protocol?
Yes, absolutely.
Okay,
We are going through each of the regulatory criteria that the IRB has to approve. It has to determine all of these conditions are met.
So is there
before
a score? Are we scoring our discussion somewhat?
Well, I would think, and it depends on the particular IRB in terms of how it does things administratively, but it may do, I mean, this is a very real example. I mean, because this is what NIH is saying for its own IRBs. Ask yourselves these questions. And so we went through the discussion about the research design. My take from our discussion was that we determined that question number one was satisfied, that it seemed to be a clear enough goal and that it was a goal that was appropriate, that the risks were appropriately minimized relative to the possible benefits. So we were gradually going through like questions, 1 and 2 are actually probably the most significant 2 items an IRB talks about. And my take on what happened here was that everybody in the IRB, and sometimes there are outliers, this was a question raised yesterday, but an outlier may just be somebody who disagrees with a determination, but nonetheless the majority votes the other way. We determined up to now that I think most of the IRB members, unless some of you disagreed and were being very shy and not expressing your opinion, but assuming everybody expressed their opinion on number 1 and 2, I thought this was a realistic discussion. You actually ultimately, even though this was a controversial protocol, came to a conclusion that both of those 2 criteria were in fact appropriately met. Some of you raised a few issues about wanting more details from the investigator, so somebody could have written that down and said, well, before we approve it, we were going to want to get the researcher to answer the question. But I think by and large, the sense was that the core aspects of those 2 determinations were in fact met. And you would keep going through the rest of these. We'll briefly go through the rest of these. We'll see how quickly we end up here. But assuming you go through everything and find that all of them have been met, at the end you will have a vote. And you'll basically say who's in favor of approving the protocol without any further questions or anything from the investigator, who doesn't want to do that but wants some specific questions to be raised, and so those people could say, yes, here's a question I think should be raised. Often what will happen, I mean, again, this is under general rules relating to procedures, so those of you familiar with Robert's rules or whatever the variation is, you will often, at the end of the discussion, ask somebody to make a motion. Do we have a motion to approve the protocol? And somebody will say, absolutely. Is somebody going to second that? I'll second it. And then you do the vote. And often it'll be the case that everybody says fine. On the other hand, you may quickly discover that a lot of outliers, a lot of people saying it's not ready for approval then, and then somebody might come up with a counter motion. Let's send it back to the researcher, the principal investigator, and ask him the following 3 questions. Or ask him to rewrite part of the consent form, right? We haven't really gotten into whether the consent form has defects and that sort of thing. So does that explain what we're talking about? Because you're absolutely right, as an administrative matter, yes, the IRB would be asked to come up with a bunch of conclusions. Now, we didn't go into all the possibilities. I mean, an IRB could just disapprove of a protocol. This is very, very rare, but it's basically saying there's no way anything even similar to this protocol would ever be approval. It's a horrible thing, and nobody should have ever suggested this because it's so risky and, you know, that sort of thing.
So everybody who participates in discussion is not, starting their statement from, I think this needs to be addressed, or this leads to disapproval. We're just going back and forth and we'll summarize it at the end.
No, I mean, somebody could certainly say something at any of these questions and saying, by the way, I want to say something here. I think the risks of this study are outrageous. We started out saying this is exposing these people who are already not that healthy. Even the healthiest of them are not going to be that healthy. You're exposing them to a risk of dying. We're having them use cocaine. What didn't we actually say about the use of cocaine that's sort of in the background, and it's sort of a more technical issue or something? What is true about the use of cocaine in addition to all these other risks we talked about? What is the status of somebody who uses cocaine? Right, it's illegal. We sort of glossed over that, but let's see now. We're talking about researchers giving cocaine to people when use of cocaine is illegal in almost every state. That might be considered a somewhat bad thing. How do you actually do that study? And that gets back to even far more benign studies. There are studies out there in terms of like having 16-year-olds drink a few beers or something and seeing what it does to the metabolism of a 16-year-old. That's a somewhat complicated study to do because of the laws relating to alcohol consumption in a lot of states. Now, again, we didn't talk about it. There are answers to these things, okay? There are rules in the states that allow, under certain circumstances, use of cocaine in a research setting. Such that, right, because the researchers would be sitting there with cocaine, which you probably shouldn't be sitting on in the first place or something. But again, if you meet certain criteria in certain laws, I mean, in Maryland, there are laws relating to doing this sort of thing, in which you would not be illegally doing this. You would be meeting the legal standards, and it may say things relevant to how the protocol was designed, which was that you got to be in a facility which has certain controls on it, and they've been perhaps licensed by the state to actually do research with cocaine or whatever else or something. But these are all things that the IRB would go through. Anybody who had a problem with a particular aspect of the study would say that, would tell his or her colleagues, I have a problem with this, and then they'll talk about it. And we haven't had anybody up to now who just said, well, I've heard the discussion and I still think this is totally outrageous and I would never approve it. But that often happens, and what will often happen as a result of even one member announcing their views and discussing them in detail, others will become convinced and say, I agree, you raise a legitimate issue, we need to get the researcher to respond to these concerns. And the bottom line will be, at that point, the IRB will know we're probably not going to approve it today. They still will go through all the other criteria because you have to determine all of the aspects of the protocol, and you want to go back to the researcher with all the questions that need to be answered or all the possible changes in the protocol. So that is exactly what would happen. There are people who are, in fact, keeping notes. Often there will be minutes. You have to have minutes. There may even be a transcript, depending on how the IRB operates. They may be tape recording the thing or something. So absolutely, this is like any administrative entity that is making decisions. This is very much an IRB is a decision-making body. Certainly from the viewpoint of the researcher, it better be, because we have the researchers out there waiting to do what we all hope, that the researchers are good, well-trained people who are wanting to learn stuff that we all benefit from. So basically, we want the IRBs to function well, and they should come to decisions. And even if they're not concluding the protocol is approvable now, they should be coming up with a route to help the investigator lead to an ultimate outcome. There's a great case, what is it, Kennedy Krieger versus Grimes, which is one of the famous cases, legal cases out there, and it happens to be, it's a Johns Hopkins entity, Kennedy Krieger, that does research on children, and this famous case was about, I guess, lead paint and lead paint consumption by kids in homes in inner city Baltimore. And interestingly, and I encourage you to read about it. It's easily, you could Google it, and I'm a co-author on a textbook that we actually use a lot of the opinion. But interesting in terms of the issue we're talking about here, that court, it's a fascinating opinion to read, because reading it, the judges, and this was like the highest court in the state of Maryland, the judges start condemning this study. And a lot of us think the study, and I'll say this too, just my personal opinions, not the government's, it wasn't actually that bad a study. But reading the opinion, the judges start comparing this to the Nazi studies that I described yesterday, and putting, you know, the canaries in the mines, intentionally exposing children to all these horrible things. And one of the things they condemn is, at one point they talk about, you know, IRBs and the administrative review bodies actually helping the researchers get the study approved. And a lot of us thought that was an outrageous thing for the court to be complaining about, because there's nothing inappropriate about even the people who are devoted to research ethics explaining the rules to researchers and helping them get the studies approved consistent with the rules. And yet you had this bunch of, you know, very prestigious judges saying, well, this is outrageous that this horrible study is happening. And it's just worth reading to see the take of a bunch of very scholarly people who were not familiar with how research is done. So the bottom line is, all of this effort is about acknowledging, you know, you often get a different take from being on the research ethics side. It's not about stopping research, it's about figuring out ways to have research go forward consistent with the protections our society thinks are appropriate. And that's exactly what the IRB is doing, basically. And that's why we do a lot of training of IRB members, make sure they all understand the rules, and we have lots of meetings so that IRB people talk to each other. And we have sessions like this where people learn what our rules are about. And as I indicated yesterday, we have a very vigorous debate now about whether our rules for protecting research subjects are doing what they should be doing. And lots of people are commenting on that. Yeah.
I think this case is the example. If you are one of the IRD person, the member of it, how do you yes or no to approve or not approve? This study is very good example. I think it's quite complicated. If we are in say yes, okay, we approve a good, okay. The question is, do there will be benefit for the researcher or not? Or there will be benefit for the public or not? So very hard to say for if we are the one of the member of IRB.
Yeah, no, and that's a good point. This is a complicated study. Obviously, it was intentionally chosen to raise a whole bunch of issues. Many studies, even a brand new study that goes to an IRB, will be pretty straightforward. Depending on the IRB, it will be a type of research the IRB is very familiar with. It will often be very low risk, and the IRB quickly knows it. And the primary reviewer will say, we're very familiar as an IRB with this type of study. We've approved many similar studies. So many studies will not be all that complicated in terms of how long the IRB has to discuss all of the issues, and some of them may get voted on and approved very, very quickly. On the other hand, there are lots of studies that require a lot of discussion. I'm sure a lot of the studies that are conducted at NIH can involve cutting-edge sort of things, and they involve interventions that we just don't actually know a lot about how well they're going to work or what the risks are. And they will lead to exactly this sort of discussion we're having here. It could take a lot of time. It could take an hour or more to discuss a controversial protocol. And again, it may in fact lead to the IRB sending it out to the investigator with a whole bunch of questions. Often you could have pages and pages of questions that the investigator is going to be asked, and the investigator will be very unhappy about all this. This is all part of the debate about, are our rules functioning correctly? Is a particular IRB or IRBs in general kind of not being, too strict in terms of raising all of these questions? So again, this is all pretty realistic in terms of you are getting a sense of what actually happens in an IRB meeting. Yeah, who has the microphone there? And you're right.
Let's say the IRB goes along and approves something, and then thereafter the research ends up discovering that they were wrong. About 5 years ago, one of the first genetic manipulations ended up, I believe, in the death of a young boy. And it basically, they did a 180 and stopped everything.
Yeah, no, absolutely.
So, I don't know, can we address that a little bit?
Sure. No, so you're raising a good point. So we are now functioning as the IRB reviewing a brand new study. That is only part of the system. And we talked a little bit about yesterday, there is a notion of continuing review, that it's not just a one-time shot, what we talked a little bit about today too. So at least once a year, an IRB has to re-review studies. But we didn't talk about one other aspect of it. There are reporting requirements on the part of researchers as the research is ongoing. And to the extent you discover something new and unexpected, and there are these complicated criteria that people debate about what they actually mean, but some adverse event occurs. So when you are treating in this protocol, you suddenly discover one of these people having a side effect that nobody ever saw happen before, or you see arrhythmias occurring at doses that you thought should not have been causing arrhythmias. What you will often do is report it very quickly to the IRB, to other administrative types in your medical center, to the entity that's funding the research study, if you're at some university somewhere and NIH is funding it or something, and you may end up suspending the study at that point and say, hold on a second, we don't know what's going on here, let's not expose anybody else to risks until we have a better sense of what's going on. Right? You were raising the issue of Jesse Gelsinger, right, who was in a genetic treatment study, and he ended up dying when nobody thought he should have died. And then a lot of stuff was put on hold, and the rules relating to those sorts of studies were rethought, and a lot of stuff happened. But absolutely, this is another aspect of the system, that as you generate any type of new information that causes you to perhaps have to rethink, well, what's the risk-benefit relationship in this study? You now learn more stuff about a possible risk that you didn't know about before. Let's not inappropriately expose additional subjects to the risk. Let's put this study on hold, and let's have a whole bunch of analysis taking place. That's just built into the system. Very important part of the system, absolutely. I mean, we could, and we're not going to end up going through all of this. So number 3, subject selection is equitable. And I mean, this is raising issues we already talked about to some extent. Who's going to be enrolled? Men, women, ethnic minorities, seriously ill persons, healthy volunteers. And that gets into the issue of not only who gets enrolled, but how are you actually enrolling these people, right? We didn't actually discuss a lot about, well, where are you going to find these people? This is a little more challenging than your average study. Where exactly do you find your cocaine addict? Anybody want to say anything about that?
Those studies usually kind of recruit from treating physicians or community centers where those patients are
already there,
articulated with.
right, okay.
So there are addiction treatment clinics, and you can get brochures there, or certain people who can talk to patients as they see them. So, you know, this is, I think, the common notion.
And it's certainly a possibility. Now, if we're dealing with the people who don't want to get treated, how likely are they already going to be at those centers? I don't know, but this is a challenge, yeah.
One of the other things that they specified was that they will include educationally or economically disadvantaged people because they do represent the population that they're interested in, but they're not going to be specifically targeted, which is to the whole vulnerability issue. But they didn't really address how they were going to deal with those people who are vulnerable once they're at the informed consent process. You know, I assume there has to be additional treatment with them as far as getting them to understand, and not just dealing with a unfair targeting aspect.
No, absolutely. So you're raising a whole host of questions that tie into not just number 3, equitable selection, but safeguards. Yeah. Right, number 4 is this vulnerability issue. We need additional safeguards for subjects likely to be vulnerable to coercion or undue influence. We've raised a whole host of issues relating to this population. This is certainly an incredibly vulnerable set of subjects. And so you're saying in terms of informed consent, we want to make sure that people actually understand what they're getting into and are making an appropriate choice. But on the other hand, these are people who are cocaine addicts. So what's going to actually happen during that consent process? And what was one of the exclusion criteria specifically said what related to informed consent? And if you recall, they specifically had a requirement that they have to be able to get appropriate informed consent from the person, that the person should be somebody capable of making reasonable decisions. So, because certainly some of these addicts presumably may be so strung out or whatever it is all the time that there's no way they could reason enough and think about what's going on to actually make a reasoned decision about being in this study. If that's the way you are, they're specifically saying, we're not going to invite you in this study. Notice this is going to be complicated in terms of, sitting down with these people and talking with them for a while and kind of making sure they're coherent and understanding what's going on. Even though they're an addict at the moment, their mind is functioning well enough. And maybe you might want, as an IRB, to have more specificity in this protocol about exactly where this consent is going to take place and what kind of tests you're going to give them at that point to make sure they're understanding. And because, it is such a challenge, it is such a vulnerable population, the consent issue is far more complicated than it normally would be. We had the issues earlier on that these people may be trying to lie to you because some of them may just want the money and just are lying left and right about their medical status or whatever it is. So, all of these issues that we've touched on them, and we're just noting we would be dealing with them in detail in terms of the IRB review. Okay, so we've dealt quite a bit with subject selection, since that was a major element of the protocol in terms of this unusual group of people. We've dealt with vulnerable coercion or undue influence. And number 5 is about informed consent being obtained. So A is, does the informed consent document include the 8 required elements? So that's in the regulation. We discussed some of it yesterday. You know, are you discussing risks, benefits, what procedures, what will happen to you in the study, all of that sort of stuff. That actually is a major element of a lot of IRB discussions. You go through the consent form in a great deal of detail to make sure it actually is covering what it should be covering. Is it describing this in lay enough language so that the people who are actually going to be enrolled in the study will actually understand what it's saying? It's not too technical, right? That's B, right? Is it understandable? Who will obtain informed consent? In what setting? Again, these are major, major elements. And again, in other circumstances, we would actually probably be spending a lot of time on the consent form, because often in clinical trials, certainly, the stuff we're talking about is actually very, very complicated, and the question is it, you know, has it been digested into being some lay language or something? And that's often a huge challenge. Yeah, we have.
Could the consent form be reconsidered by the patient?
Could the consent form be reconsidered? But what, I'm not sure I understand, by the patient.
Let's say during the process of this whole protocol, the patient starts saying, well, you know, I didn't realize that, and I'm not interested in doing this anymore.
Oh, absolutely. The whole purpose of consent is to give the person, the prospective subject, enough information that they could think about it and decide whether or not they want to be in the study. Yeah, so first of all, the patient, the person you're talking to, you're inviting into the study, gets all this information, may be given the form, may take it home and be given a week or so to think about it, to discuss with family, friends, whatever it is, and ultimately they make a decision. They're not in the study until you've completed that process of making sure they get all their questions answered and then decide they want to be in it. And as was noted, at any point, the person could always end their participation in the study.
I understand that it's voluntary and they can leave, but I think what I'm getting at is that as they become more familiar with it, they may suddenly realize consequences that weren't in the consent form.
Oh, you're saying while they're in the study? Okay, absolutely. And if they do, it's perfectly acceptable for them. I mean, it's the right thing for them to, at any point, make a decision to not be in the study anymore. Absolutely. Now, ideally, we're starting out with wanting the consent form to be clear enough, and the process by which the investigator talks, or whoever does the consent, talks to a prospective subject so that you've hopefully laid out clearly enough all of those issues. Certainly not a good thing if this was an important part of a study and that it had certain risks and the person doesn't realize these risks existed until halfway through their participation in the study. That's ideal, not what you want. I take it you would...
Just a quick question. I'm okay. Would they include a section about the storage of information because of the legal aspect?
Yeah, okay, so would they discuss storage of information? There is commonly a statement relating to confidentiality and privacy. It depends on the study and how sensitive the information you're collecting is in terms of what they're going to say. I mean, obviously, if it's a study enrolling people who are HIV positive, hopefully it will say a lot more about where the information is going to be stored, who has access to it, that sort of thing. One of the related, more complicated issues is, and that would be actually relevant, we didn't talk about this in this study, there is a thing called a certificate of confidentiality, which is a very complicated and much debated type of legal document that there is a federal law saying you could obtain this certificate for a particular study. And what it does actually is it is a legal barrier preventing any entity to use the law to obtain the identities of the subjects in the study. Because remember, here you could certainly see that there could be the authorities would actually love to know. They think in their community there aren't too many people abusing cocaine, and they certainly want to get rid of anybody who is doing that. So they may want to have this information. So what you would contemplate doing, and this would be an IRB issue, well, let's think about, has the researcher gotten a certificate of confidentiality? Why not? Okay, and it's actually NIH that is empowered to provide these. So another great issue. So I mean, these are all great topics. Yeah, that's number 7, privacy and confidentiality. We already did 6, risk of subjects are minimized. Okay, so I guess we're sort of wrapping it up. You guys were a great IRB. You did exactly what a wonderful IRB would do. Any final thoughts anybody wants to raise?
I have a comment on the issue that was made like 20 minutes ago, and
Yeah.
they were talking about the
Closer
controlled
to the
environment
microphone.
versus not controlled environment, and what we want and being.
Oh, in terms of the subjects and what
Yes.
information we
so
want?
one advantage that the investigators have is that the half-life of cocaine is about 20 minutes or 30,
Oh,
if I'm
okay.
not mistaken, which is great for them because in that case, their environment is not as much altered. I mean, I know that the lady behind me brought like what they eat, what they do on a daily
Right,
basis,
right.
but since they're monitored for that half an hour afterwards, it helps them out. So.
Yeah, no, an excellent point. Yeah, I mean, this is a complicated thing. There's a lot to think about in these studies. But hopefully, again, having IRBs review studies in this way is a good thing, that it makes the studies better. And again, keep in mind, it's not about stopping the research. It's about making it go forward with appropriate limitations and appropriate protections. Yeah.
I have a brief technical question. So the criteria 7 is about storage and confidentiality and all that stuff. It was in this particular informed consent document, but it wasn't addressed in the protocol.
Okay.
Is that something where it has to be in both, or is just one or the other okay?
The protocol should actually,
Okay,
that's the
so it should
document
have it then.
telling you what happens in the study. The consent form is not the document creating the rules in the study.
All right.
That's a good point.
So
If
this would
if
go
it's
back
not in
until
the
it's
protocol, you should make sure that it's in the protocol. Absolutely. The consent form should be describing what the rules that are created elsewhere that create the study are doing, and it's the protocol that creates the study. So that would be a good point, absolutely, to raise. Okay.
Sometimes there's just, again, in layman's terms, there's a lot of thought that many of the research protocols are done over and over, and that could the IRB basically say, been there, done that, we've seen this before, and we don't think it's going to contribute any more general knowledge?
One of the relevant things for the IRB to look at, yes, is this aspect of what are we learning from this study? If it's repeating some other study that has taken place elsewhere or certainly been done multiple times, that is certainly a relevant criterion in terms of looking at the relationship between risks and benefits. Now, often the way that will come up is you probably more likely have a lot of incredibly low-risk studies that don't generate a lot of information, but it could be students conducting this study or researchers just learning how to do studies or whatever else. So probably IRBs are not really likely to raise this as a really big issue in a very low-risk study. In a higher risk study, you're far more likely to say, wow, you're exposing these subjects to significant risks, and we don't think you're actually learning new information, generating new information, because there are plenty of studies that already have answered this question, and it would be far more likely in that scenario to perhaps have the IRB come along and reach a conclusion that we don't see a good reason to do this study. So. Okay, so you're raising the issue of animals instead of people. Well, that's the standard issue of what can we learn from the animals, and that people are different than animals. And often we certainly reach a point eventually, if we want to do something in people, that we have to know the differences in terms of what their responses are on the people side versus the animal side. But we didn't get to it, but your starting point in terms of doing this study in people in the first place is that you've minimized risks. If you haven't done your earlier stuff, which we didn't get into, which was if this is a brand new compound, you would have exposed a bunch of animals to this compound and would have had to generate a bunch of information about it in terms of it not inducing cancer in cell lines and a whole bunch of other things before you ever got near reaching the point where you were even allowed to expose a person to it. So yes, doing research on animals is a major part of it, but often it occurs before you even reach the point of doing the research on the people. So absolutely, these are just aspects of a large process that we only covered part of today. And that's what the rest of your course is covering, all sorts of aspects of it. So, okay, great. Thank you. You guys are a wonderful IRB. Wonderful session. Thank you so much.
Thank you.
Welcome.